All right. Well, last fortnight we talked about inflammatory bowel disease and really sort of went through cases of quite chronic gastrointestinal symptoms. This fortnight is we're just going to cover the rest of the gastrointestinal tract. So there's no way that this is going to be exhaustive. We're not going to talk about every single disease process we get in the gastrointestinal tract. But there's a couple of clinical scenarios I want to just run through, not because they're examinable necessarily, but because they're really common and it's good to have a sort of approach, particularly with why we're doing what diagnostic tests and what we're looking for. So the first clinical situation I wanted to talk about is actually acute vomiting and diarrhea, because we haven't covered that. So 2-day history, 4-year-old dog, mixed breed dog, 2-day history of vomiting and diarrhea, history of rubbish ingestion. Now, a fortnight ago, we went through all the diagnostics for non-gastrointestinal disease. So I don't want to cover that again, because we've kind of got a nice list of, the TLI, CPLI, blood, C4, all of that stuff. What I want to really focus on is this is gastrointestinal disease. Once we've ruled out the extra gastrointestinal stuff, what tests are we going to do and why are we doing them in this case? So obviously you've done bloods, you've done T4, you've ruled out pancreatitis and stuff on blood tests. What imaging are you going to do? Let's be specific.
Radiography and or abdominal ultrasound. I think if I was on, I would do radiographs because I don't know how to do a good ultrasound.
You call me from.
That's right.
Good. Now, the history is a two-day history of vomiting and diarrhea. Are you going to
do anything?
But you hadn't?
Oh, I actually wouldn't do any diagnostics, to be honest.
So, and you get a feel for it. This is why I sort of hate putting cases like this in, and the reason why it's not examinable is because you can't say it's really bad, it's not eating, it's flat, because it's not objective. But, clinically, there's ones that you're like, oh, I really need to look into this more. And there's ones that you're like, yeah, you ate rubbish. See you in 5 days. So I think RADS and ultrasound are absolutely indicated if it's one of the bad ones. But if it's one of the acute presentations with a known dietary indiscretion, I would probably do symptomatic management before I did any further diagnostics. Is everyone on board with that? Yeah, I think a lot of people sort of say, RADS are non-invasive, but they often need a sedation to do it. They need to be restrained. It's a day in hospital. We know that stress impacts gastrointestinal microbiome and function, and therefore maybe we should hold off. What about fecal testing?
If there was any, if they'd come from a crowded environment or they were a very young animal, I would do fecal parasite testing, but I wouldn't do it otherwise.
And what about if the history was kind of a week of diarrhea predominantly?
I might do some Giardia testing with the antigen test. Yep,
good. Yeah, so that's the most sensitive test for picking up Giardia, the fecal antigen test. What other tests might you be able to do in clinic if you don't have access to an antigen test?
PCR is
good.
Very useful.
Yeah. Let's put PCR down to discuss for other differentials later, but say we're sort of thinking Giardia. What's another test we could do just right in our clinic without sending out anything and get results straight away?
Cytology.
Yeah, good. Fecal cytology or rectal cytology. Does anyone do it? You do? No. Josh says no. To be fair to Josh, well, you're probably not seeing that many just acute gastros really these days.
Yeah, even in GP, I didn't, so I was bad. I should be.
I find it's cheaper to send it to the lab and just add it.
Yeah.
To, like, yeah.
Is it Is it as diagnostic though?
That's a good point.
Yeah.
Well, for Giardia cysts, it probably is. I mean, they're going to still be there 24 hours later.
Are they usually cysts or are they usually trophozoites? Is that how you say that word?
I don't know.
I've only seen it red, I think. Sorry.
I definitely used it in the Middle East when there was no lab to send it to.
Yeah.
I had a couple of nurses that were veterinarians from the Philippines who were really good at finding Tritric and Giardia on fresh sample.
Good. Yeah. I don't know if Sam was glitchy for anybody else, but so Sam's worked in the Middle East, and she had some nurses from the Philippines who were excellent at cytology, differentiating Tritric from Giardia. Does anyone know what you're looking for if you're differentiating Tritric and Giardia? No, it's the motility pattern.
Oh.
It's really specific and you'd never remember it. So I literally read it last night and thought that's funny. Tritric has flagella only at one end of it, so it goes forward. Giardia has flagella all over it, so it has a random tumbling motion. So there you go. If this was a cat, that would be significant, but we're talking about a dog, so I won't hold it against you. And
at a 5-day history, where I mean, would you want a fecal PCR for a whole diarrheal panel anyway, for morbidities?
This is a test that, you know, the owner can collect it at home and drop it in. It's definitely not, it's non-invasive. It's not going to cause, you know, disrupt this dog's gastrointestinal function in any other way. So yes, I would. What else are we looking for on PCR?
Bacterial infection.
Yeah, let's talk about that a little bit. I want to go back. I just want to make sure that we've addressed all of the rectal cytology indications. We talked about protozoal diseases. Are there any other indications for rectal cytology?
One of my colleagues does it all the time for acute diarrhea and chronic diarrhea, and my understanding was that it's not useful anymore, other than for Giardia. And I just wanted to know what the current thinking is, whether you get a predominant of, you know, the seagulls and the hairpins. Do you actually care what you see there? Like, is it more of this or more of that? Like, is that relevant?
Not at all. No. So for bacterial causes of gastro, it's completely useless. But what you're going to see is the protozoa, fungal organisms show up really nicely on cytology as well. Right. This is not a problem for us in Australia. Like, we don't really get gastrofungal diseases. And an algae called Protopheca, but to be fair, I'm not going to recognise that under a microscope. So I'm going to need to send it out anyway, because it's something I think there's like a couple of cases reported in Australia or something. It's certainly not common. Does that answer all your questions? Like, basically bacteria, waste of time. You need a PCR for bacteria, and even the PCR is hard to interpret, isn't it? So we'll come back to Matt's question. So which bacteria do we get on our PCR panel?
Campylobacter, Salmonella.
Mm-hmm.
There's all the Clostridium.
Mm-hmm.
And that's
okay.
Is that it? I remember.
I think so. Yeah. Okay. So how significant would it be if you got a positive on a Campylobacter?
I think it's a tricky one because it depends if they're often you won't treat it. So the significance, I guess, is arguable if you're not going to treat it. If it's a repeatable thing and you've tried to manage everything else, then you can potentially treat it. But
is there any historical information that might make you think it's more significant than
I guess if it had a raw chicken diet that predisposed.
Yeah. Predisposed to shedding. So there's campy going out. So that's, I think that's really hard to interpret in a raw food situation. And I usually, antimicrobial stewardship wise, won't treat a dog that's been on a raw food diet who's got Campylobacter, because they're probably quite immune to it. Like, they've been exposed to it so many times. I'd be very surprised if one time it set up an infection.
Can I jump in there?
Yeah.
In clinic, where I would say 50% of dogs in my clinic eat raw diets, I rarely see Campylobacter on a fecal PCR.
Do you think that's because it's not in the diets they're using?
No, I think that they're.
Yes, not good.
What's that? Sorry.
Or maybe the PCR is not sensitive enough.
No, because I see it when I'm working up recurrent GI diseases, and it sort of rationalize whether it actually does need to be treated when I do see it, actually. But yeah, to me, I think it just doesn't get the like, from a pathobiont point of view. I just don't think it gets constrained by other probiotic taxa, and so it doesn't really get a preponderance. And therefore live. Maybe, yeah.
And do you think it's more significant as a cause of disease? Than we? Yeah, right. Okay.
Yeah, I do. Yeah, and also because I watch for it, because particularly for dog with the APN chicken necks Melbourne study a few years ago, I am mindful of watching for campy when I have a dog that is eating chicken necks.
So there's been studies in raw food diets, and I can't remember what the actual number was, but Campylobacter was over 10% of the raw food diet studied overseas, not Australia. So it's definitely a common contaminant. And then on top of that, we have, and they're in the manufactured raw food diets that have been sort of, snap frozen and processed to minimise pathogens. But then we've got people feeding bones and chicken necks and things like that. So I think exposure to camp is quite high.
The only other thing that we do in our clinic is we ask people to freeze their chicken for 10 days before, or 10 to 14 days before feeding it, to reduce the Campylobacter levels. Sorry, I forgot about that. So that might be where the incoming threat, and then a lot of people use kill steps or do some sort of kill step if it's commercial, and probably the US CAFO intensively feed. I mean, obviously chicken's intensively fed here, but potentially we have a little bit better meat supply with regards to incoming threats of bacteria.
Yeah, okay, interesting. We're definitely clinically, from my perspective, we see polyradiculoneuritis almost exclusively in dogs fed raw chicken. And that's been associated with molecular mimicry from exposure to Campylobacter. So I think there's definitely campy in the chicken necks, but I don't know at what proportion. I don't think the testing's been done in Australia.
Matt, just a little bit off topic, do you see much in the way of congenital protozoal infections in those raw meat diets? Because at the moment I'm doing a bit of work in Canberra, and it's showing up quite commonly in so-called bath diets.
So in do you mean Neosporosis?
Yes.
Like congenital protozoal?
Yeah. I mean, I happened to see a Great Dane last week that was a definite positive for toxo, and and it would probably it was a positive on Neospora at the minimum titer that it could be positive. I saw in Adelaide a case where the bitch was fed raw beef from the farm next door, and numbers in the litter had neurological signs, and there was a lot of euthanasias in that litter. Result. And this dog that I saw, it had a litter mate that had some sort of illness too, and I'm not sure what it was because I didn't see that.
A couple of things in there. Toxo doesn't traditionally infect dogs badly. I think when there's a lot of studies that talked about toxo in dogs, and now they've realised that it was actually neo. what was reported as toxo, they're now thinking it was neosporosis the whole time. So we sort of think of protozoal infections as toxo does cats, neo does dogs. Heaps of dogs have been exposed to toxo and will test positive because they eat raw meat and scavenge and get into whatever they can. So they've been exposed to it, but they don't really get the cysts and the recurrence and the infectious, the actual kind of pathology associated with it. But congenital neosporosis is really interesting. I'm not sure about them. I think the processing in most of the manufactured raw food diets minimizes neosporosis or neospora organisms. But certainly where we see it is dogs that have been to farms or been fed offal or raw, unchecked raw meat, basically. But it's kind of everywhere. It's really, really common. Yeah. Neospora, it's just wrong place, wrong time with dogs like in utero or, yeah.
Neospora is more likely to come from beef, whereas toxo more likely from sheep, apparently.
Yeah, okay, interesting. That's really interesting. Roux, toxo comes from roux, doesn't it, as well? There's a sheep or roux as the herbivore. I think you can get either.
Not sure about that, but I do know they get hydatid cysts.
Yeah, right. Yeah.
Yeah, I think there's a lot of ways that raw are being done. Some are very stupid and some are like reasonably risk mitigated. So yeah, I think
it's difficult to know, isn't it, as a consumer, who's doing it responsibly and who's not.
Freezing 48
question.
Freezing 48 hours is supposed to kill Neospora.
Is it? Okay, so most of the raw food diets come frozen and have been frozen in a very specific way and rate to kill organisms. So I assume that they're very low risk.
Do you have, Matt, do you have specific instructions for freezing for your clients? If they're feeding raw meat, does it depend on the meat and does it depend on the organism? Like, does it kill all of them? 10 days?
No, I mean, no, it's not a quick answer. I mean, yes, like 10 days freezing for poultry is something, depending on the gastro resilience of the dog, I mean, a lot of the time I wouldn't advocate for raw feeding, or it should be dipped in boiling water for 90 seconds, allowed to cool. Right. No more than 90 seconds so that the bone doesn't cook and cause foreign bodies, that sort of thing. And it depends on whether it's pet grade, human grade, chain, off the neighbor's farm if they have a feral dog problem, etc. Yeah, but yeah, that's the general rule. But yeah, finding something that has a kill step, pasteurization, or they have bacteriophages, and it's definitely something. But in Neospora, we don't see it in our clinic, but I definitely see that when we have neurological workups, that the neurologists always want to test for it, which is absolutely fair enough, that support it. But we've not had a positive in our clinic in the last 20 years.
Wow. Thanks.
Thanks.
The only cases I've seen Neospora in a raw meat, like human meat, fed to immunosuppressants. Most adult dogs can deal with it if they've got immunocompetence. Okay, so we digressed a fair bit from Campylobacter as a cause of gastrointestinal science. What about Salmonella? If you get a positive Salmonella on your PCR?
Yes.
Significant?
Yes.
Significant? Yeah. Always significant?
Probably, no, not always, but I think I'd be clinically suspicious that it was a problem.
Would you? The 30% of dogs are carriers, normal dogs are carriers of Salmonella will test positive on a PCR. I don't agree with that in my experience. I rarely get positives of Salmonella, but the data shows that Salmonella can exist in dogs fed a commercial diet without pathology. What clinical signs do we see in a Salmonella infection?
Profuse watery diarrhea.
Yeah, it's pretty, it's a bad infection. They look like parvo dogs, essentially.
Yeah, hemorrhagic.
Hemorrhagic, exactly, yeah. And it's really flat. A lot of them are pyrexic. A lot of them have kind of symptoms of sepsis. Because I don't know whether it's actually Salmonella systemically, inflammatory cytokine systemically, or whether it's mucosal breach and all of the other microbes getting into the systemic circulation, but they're often really sick. And that's where I think that's a really significant finding if I had a hospitalised, really unwell patient with a positive salmonella. What about Clostridia? Significant?
Depends on the toxin. Depends if it's high range or low range CPA or other toxin, I guess.
Is there any correlation between the range of, so when they do the PCR, they're testing for the gene toxin. Is there any correlation between the number of genes capable of producing and the toxin?
Sorry, you cut out there.
Sorry. Is there any correlation between the number of organisms capable of producing the toxin and the actual amount of toxin when you quantify it?
No.
No. So is there any correlation between the number of Clostridial organisms and hemorrhagic diarrhea?
Organisms or genes?
Sorry, genes in a fecal test, on your fecal PCR.
Yes.
Is there?
I don't know.
No.
No, is this between like a CPA low range versus high range?
Yeah, so the point I'm trying to make is that the fecal PCR tests for Clostridial organisms, and it tests for like the different types, and it tests for the gene capable of producing that CPEA toxin, which is absolutely endotoxic and will cause symptoms if the toxin is present. But there's no correlation between the gene being present and the toxin being present. So you can have a lot of CPEA producing bugs without having any gastrointestinal signs or any toxin present. And you can also have a lot of Clostridial genes in the feces that are commensals and not associated with disease. So unfortunately, while Clostridia can cause really profound gastroenteritis, we can't really test for it because there's so many commensals with a PCR, I should say. Are you researching that?
Me?
Yeah.
Oh, I'm just having a look on Vet Connect. I just want to see what IDEX says at the bottom of their thing regarding. I'm just checking. So a high range CPA gene quantity of C. perfringens and enterotoxin A gene can be associated with clinical diarrhea.
I think they're quoting their own study there and not the other studies done on that subject.
It sounds pretty vague as well.
Yeah.
Yes.
Can you request toxin? Can you measure the toxins?
You can measure the toxins. I think there's I don't know what the test technique is, but we don't have good correlation with clinical disease, unfortunately. So absolutely Clostridia cause really profound gastroenteritis, and they're particularly associated with hemorrhagic gastroenteritis. And when a dog's got really profound hemorrhagic gastroenteritis, you can probably assume you've got Clostridial overgrowth because of the motility changes and things associated with that, no matter what the original cause is. So that's one of the reasons why probiotics or metronidazole work so well in these cases. Either work, obviously, but what's the downside of using metronidazole with a hemorrhagic gastro? There's a few. But
you get it's going to cause dysbiosis of its own for many, many weeks afterwards.
Yeah, exactly. And what's the incidence of recurrence of severe diarrhea in patients given metronidazole versus not?
70%.
Yeah, I was actually going to say 50, but you might be right. So recurrence of diarrhea is much, much more likely when they're given metronidazole because of the dysbiosis you cause. So have you ever had those patients who are like, oh, they just need to stay on metronidazole all the time? It's because they're getting these wild swings in their bacterial population and they're getting relapses, and we're leaving them vulnerable to opportunistic pathogens. Whereas probiotics, the incidence of recurrence is much lower. So if you're going to treat Clostridial overgrowth in your hemorrhagic patients, treat it with probiotic rather than with, and prebiotic rather than with metronidazole, if you can. Also very responsible from an antimicrobial perspective.
So if you're trying to rule out antibiotic responsive IBS, it's absolutely a rule out of everything else, because you're going to create antibiotic responsive diarrhea if that's your first step, right?
Yeah, absolutely. And this is where I think the literature's just changed so much in the last 10 years. So if you're reading a textbook, the recommendation is still rule out antibiotic responsive gastrointestinal disease, but it's tricky to do in a responsible way now that our kind of, I guess, antibiotic prescribing behaviours are changing.
I mean, the paradigm, could the paradigm shift be more like the framework be more like microbiome manipulation responsive diarrhea?
I love that, yeah, and I would love to see the veterinary literature shift towards that, because that's exactly what we're doing, and there's more than one way of doing it. Which the food, I mean, all the food companies have been adding prebiotics and stuff like that in their gastrointestinal diets long term. They've been, we do that without really knowing what we're doing, because the food companies just do it for us. But certainly with the procolon and things like that on the market, it's such an excellent choice for dogs suffering from this. Also, hospitalisation time is nearly halved in dogs with hemorrhagic gastro who are treated with probiotics. Okay. So I think we've talked enough about our fecal PCR. Does anyone have any other specific questions about a fecal PCR? Okay, excellent. Let's move on to a different case.
I do have one. I'm sorry to say, like the classic kind of puppy farm, which I'd call like the quadruple whammy, where they've got like circovirus, maybe Campy, maybe Giardia, maybe
Corona.
Corona. And just think, that's puppy farm syndrome. I mean, say I didn't quite get the start of the 8 a.m. start, so I'm not sure of the exact segment of the animal, but if it was a younger dog, do you pay, obviously parvo, but do you pay any attention to the other GI viruses as part of the mix? Like if it was like a puppy that had a 7-day history or a 5-day history of vomiting and diarrhea?
I pay attention to them in so much as I sort of say, there's so many reasons for this dog to have diarrhea. I'm going to treat this supportively. Basically, all of the viral, we can't treat viral causes specifically, so we're just going to do supportive care. So if I get a positive on the virus, I usually say to the client, oh, he's got circovirus, it's probably infectious, make sure that your other dogs don't develop symptoms, keep an eye on them, this is what we're going to do. So I kind of use it as more a client tool rather than like I'm not going to go into it. I really like the fecal PCRs because I feel like it helps us to trend what's going on in our local area. So when we get a run of dogs with diarrhea and they're all testing positive to corona, I'm thinking, oh, it's probably a particularly pathogenic corona. And same thing, we've had sort of runs of Giardia and things like that, and that's when there's been heaps of rain and the water supply is a bit dodgy and all of that. So I think it's good to know what's going on, but I don't necessarily attribute all of the clinical signs to the virus.
Thanks.
Okay. All right. So next case is going to be a 7-year-old cat with chronic diarrhea. I'm going to say a 12-year-old cat with a history of chronic diarrhea, who has just started losing weight quite rapidly and despite having a very good appetite. We've done all our blood tests and stuff. The thyroid hormone level is normal. The cobalamin level is low. And the guts feel palpably thickened on abdominal palpation. So you do an ultrasound, and I might actually just show you up here. I'm sharing my screen and I never know what's open on there behind there. Am I ready? 3.
Can't be that bad, Anna.
Well, I hope so. You just never know. There we go. Not too bad. Okay. So I don't know if anybody's done very much ultrasound, so I'm just going to talk you through this image. And I'll make him bigger. All right, so this is a picture of the ileum in cross-section. The gastrointestinal tract has 4 layers on ultrasound. What are they? Somebody?
Mucosa, submucosa, muscularis, and serosa.
Thank you very much. Excellent. Which ones are black?
The black is the mucosa and muscularis.
Excellent. Good. So if we go from lumen, which is this white, where the 1 is, and then we go mucosa, submucosa, muscularis, and then the thin white serosa. In the ileum, what do we expect the ratios of those layers to look like? Which should be the thickest?
I was thinking that they should be the same. Like, I mean, the mucosa and muscularis should be similar. And the serosa and the submucosa similar as well. Yeah.
So the muscularis, submucosa, and mucosa should all be pretty similar when we get down to the ileum, and almost identical when we get to the colon. If anything, the mucosa is allowed to be a little bit thicker than the other layers, but particularly the muscularis and the submucosa should be about 1-to-1 ratio. And if we get muscularis 1.3 times the thickness of the submucosa, that's significant. So tell me, in this image, what are we seeing?
Thickened muscularis, yeah.
Absolutely. And you can see other loops here. So it's more than just one little stretch here that are affected. So I would say, just based on this, we have diffuse muscularis thickening throughout the small intestinal tract. I obviously can't say whether duodenum is affected or not, but what in this situation, what's the most common differential?
That would be lymphoma.
I agree. Yeah.
I think the IBD would also affect the muscularis, but would expect the mucosa to be affected as well.
I agree, but unfortunately, because we can only measure kind of little bits of a millimeter, it's much harder. The changes in the mucosa just don't show up on ultrasound as well. But certainly that degree of thickening throughout the muscularis layer, accompanied by the weight loss and unwellness of the cat, I'd be thinking this is probably IBD with a history of chronic diarrhea, which has transitioned to small cell lymphoma. Why am I saying small cell lymphoma specifically rather than large cell lymphoma?
Because it's diffuse.
Excellent. Yeah. Now, small cell lymphoma ever transition to large cell lymphoma?
Sorry, what's the question?
Does small cell lymphoma ever transition to large cell lymphoma?
I don't know that question. I wouldn't think so, but anything's possible.
Yes. Typically not, but we do. There's sort of almost 2 syndromes. So IBD can transition to small cell lymphoma, which is the kind of sequence that normally occurs. But IBD can also cause a sort of spot mutation and large cell lymphoma. What's the difference in ultrasound appearance of large, or behaviour of large cell lymphoma in the alimentary system compared with small cell?
Small cell's much more benign, whereas large cell is going to knock them over quickly, sort of thing.
Yeah, absolutely. And what would you expect in ultrasound?
The lymph nodes, would that be a change in the mesenteric lymph nodes?
Yeah.
Large cell lymphoma, they would be really large.
Yeah. So large cell alimentary lymphoma is much more likely to affect the lymph nodes. And there's another change. We had really nice layers still on those images. Would we see those layers if it was large cell lymphoma?
It looks more like a mass, like you get lots of layering and
exactly
loss of the lumen, that kind of thing.
So large cell or aggressive forms of lymphoma tend to be focal lesions and cause loss of layering and lymph node involvement, whereas small cell lymphoma is often confined to the gastrointestinal tract, can go out to the lymph nodes, but often sort of sticks to the gastrointestinal tract. So say we did have a mass. So this was our 12-year-old cat, and instead of seeing that diffuse thickening of the muscularis layer, we saw a focal mass. What other differentials other than lymphoma there?
No carcinoma.
Good.
mast cell.
Yeah.
Can have a fit
Leomyosarcoma. Yeah.
Sorry, say again.
Leomyosarcoma. Oh, sorry.
Yeah. Good. Excellent.
Sclerosing hyperplasia.
Thank you.
Granuloma.
Yes, granuloma, good one. I didn't have that on my list. Let me tick off stromal cell. So we said leiomyosarcoma. Are there any other stromal cell tumours?
The gist.
Yeah, the
Gastrointestinal stromal tumours.
Yeah.
What do you mean? Or
Yes, yeah, exactly. So there's two tumours that arise in the stromal tissue of the small intestinal tract, the leiomyosarcoma. Which layer does that arise from?
Smooth muscle.
Good, exactly, yeah. Or the gastrointestinal stromal cell tumour, which arises from any of the connective tissue in the gastrointestinal tract. Histologically very difficult to tell apart, behaviourally quite different. Leiomyosarcoma, so say we did an aspirate and it came back non-diagnostic blood contamination. Which of our differentials can we say, oh, it's less likely to be that then if it's not exfoliating?
lymphoma.
Good, excellent. So we'll take him off the list. What about carcinoma? So it does usually exfoliate. Carcinomas are typically inflammatory. So you usually get a hint that it might be a carcinoma. So even if you don't get carcinoma cells, they'll say atypical blah with a neutrophilic infiltrate or something like that. So you should get a little indication that it's carcinoma cytologically. There's one other tumour we didn't talk about. I can't even give you hints. Plasmocytoma.
Which one, sorry?
Plasmocytoma.
Uh-huh.
More common in cats, but they tend to exfoliate quite nicely as well, similar to lympho.
Do they get histiocytic sarcoma?
Cats?
Mm.
I don't think so.
Mm.
I really like your suggestion of granuloma. I sort of had neoplasia in my mind and I put it on there. Absolutely. What sort of infectious diseases might cause a granuloma in the gastrointestinal tract?
FIP.
FIP, good. Others?
Worm?
Fungal infections.
Fungal, good. So crypto in cats can cause focal gastrointestinal lesions.
Foreign body, like a embedded foreign body. Be pretty unlucky, I think.
Is it?
Well, it'd be lucky for the cat probably if that's what it was. If it was,
Yeah, totally.
if it was focal, but
Yeah, it'd be so good.
I think I've probably told you guys, I had this Frenchie with, I thought it was pyloric stenosis on ultrasound. He was just chronically vomiting, regurgitating, he couldn't keep anything down. So we sent him to surgery for a ZY pyloroplasty where they take out the pylorus and kind of attach it, like widen it, and send it off for histo. And this bloody dog had eaten a berry that had hairs on it, and it had gotten lodged in its pylorus, and the hairs were all stuck in the wall, like right around the circumference of the pylorus, and caused a granuloma. So all the things, like the breed that gets pyloric stenosis genetically, it wasn't actually true pyloric stenosis. Dog's doing well, which is nice.
So zebra, not a horse.
Had
It was a zebra, not a horse.
It was totally a zebra. I nearly fell off my chair when I got the histo report. And the lady's like, oh yeah, we've got those berries hanging over our fence. Of course. Good. Okay, so on our cytology, it wasn't just inconclusive. We got a whole heap of eosinophils and neutrophils and spindle cells. And your ultrasonographer said, oh, that felt crunchy when they did the aspirate.
Sarcoma.
No. Well, actually, It's it could be a sarcoma easily, but
eosinophilic sclerosis, whatever that is.
yeah. I
That's what
don't
it
know
is.
why they've named it such a hard thing to remember. Feline gastrointestinal eosinophilic sclerosing fibroplasia. So it looks and behaves like neoplasia. Sorry, Pooja, did you have a question?
No.
Oh, sorry.
Sorry.
So it looks which breeds are typically affected with this?
Ragdolls? Are they?
Good, excellent. Yeah, can be any cats, but mostly purebreds, mostly long-haired, and almost always ragdolls. So like 13 out of 17 in the biggest case series or something like that. Where do they normally arise in the gastrointestinal tract?
Is it ileum? Or near
Yep,
ileum?
ileum's one. There's 2 locations that they like to hang out. Sorry
Is
about
it
that.
pylorus as well?
Yes,
Yeah.
pyloroduodenal junction. Yeah. So an interesting thing about these, particularly in those 2 locations, cancers don't like to spread from stomach to small intestine or from small intestine to large intestine. They typically stick to their segment, particularly lymphoma, because the lymphocytes that are addressed to the stomach stick to the stomach, lymphocytes that are addressed to the small intestine stick there, and then the colonic ones stick there. So it's quite rare to see neoplasia traversing across a junction. So when you see a pyloroduodenal junction mass, it's less likely to be lympho and more likely to be this FGESF. And it's got a really distinctive feel on aspirates. I don't know if any of you are doing ultrasound guided aspirates, but it feels like putting your needle into an eraser. It like grabs the needle when you're trying to move it, and it feels crunchy. That's a really sort of I often look at those and see them and say, oh, that's, do the FNA and say, that's what this is going to be. Make sure you put on your form, consider blah, blah, blah as your differential, because the pathologist won't make a call on it not being neoplasia unless you've told them that that's the location and that's what you think it is.
Great.
Go ahead, Matt.
Great. I was saying that's a great tip.
Okay, what about if it was a Leomyosarcoma? Are we likely to get a diagnosis on cytology? Rarely. Yeah, but people shaking their heads. Very rarely. What paraneoplastic signs might we be able to look out for, which might help us make the diagnosis when our cytology is non-diagnostic?
Or a Leomyosarcoma? There's like something there, I know.
I can see
Calcium levels?
not calcium. They're the coolest tumours. They do the best paraneoplastic things.
Is it? I feel like it's got something to do with like bone marrow or something. Yeah. Do they get like pancytopenias or something like that?
No, the opposite.
Opposite. Okay.
Yeah, they get erythrocytosis. So
yeah. Okay. Yeah.
Yeah, so they often produce an EPO-like substance, which causes erythrocytosis. So that's one thing they do. And then there's another thing that they do. I don't know if you ever dealt with a dog who had, Josh, you might not have started with us yet, dog that had bladder leiomyosarcoma, which had metastasized everywhere. So they produce an insulin-like growth factor 2 like substance, which actually acts like insulin. So they present like dogs with insulinoma sometimes.
Okay.
So with hypoglycemia. And then the other thing they can do is cause nephrogenic diabetes insipidus. So essentially, if it's weird and it's non-diagnostic cytologically, take it out and the patient will feel better.
Yeah.
All right. So anybody have any questions about neoplasia? We obviously haven't covered treatment or anything. Essentially, all of them, you want to take them out apart from the FGESF ones. And the diffuse lympho, don't take them out. Very invasive.
I remember in America them saying adenocarcinomas were more likely at the two ends, and
Yes.
lymphoma or mast cell tumours in the middle, anywhere.
Has anyone seen a
sarcoma in the middle?
A sarcoma? Yeah. Has anyone ever seen a mast cell in the gastrointestinal tract? I've seen one in a lot of years. So beg your pardon?
So I've seen one in a dog, the schnauzer.
So I feel like this is quite it's quite common in the literature, but it's not actually my experience that it's common in practice. So definitely worth having on your radar. But mast cells, like by far more commonly distant from the gastrointestinal tract and causing gastrointestinal side effects by histamine release rather than local effects.
With regards to differentiation between neoplastic and inflammatory processes, have you looked at like serum haptoglobin or TK1 biomarkers for differentiation? Because I think like Bristol, I think the university does some, and certainly in the States, there's commercially marketed like haptoglobin neoplasia indexes for cats to try to differentiate those. Do you think that there's any progress or confidence that we could have in like anything within NATA on the horizon with that kind of testing?
Definitely on the horizon. So there's blood tests marketed that are screened for so many different biomarkers, which are really great, have really great potential, but we just don't have that longitudinal study to show that marker predicted onset of that before it was either clinically evident or sort of, I guess, diagnosed and treated. So we might have this correlation between cats having a gastrointestinal mast cell tumour and this biomarker in circulation, but we don't know at what point in the development of that disease that's a useful test to have. Mm-hmm. So I love that people are sending off the tests because it increases our data available to us and therefore our utilisation of those tests in the future. But I wouldn't use them for diagnosis at the moment. Mm-hmm. Okay, we've got 10 minutes. One more subject. Does anybody have any requests? I didn't get it ready. I left my textbook open on the anal furunculosis page in our office, and my dog was lying down looking at it. My husband took a really good photo. His name's Toot, studying bums. My husband's not veterinary and he does not like it when I leave my textbooks open. Okay, so do we want to talk about bums?
I do, because this is probably not where you wanted to go, but I want to talk about anal sac disease. You might say go talk to a dermatologist, but yeah, is there anything that we can talk about anal sac disease?
Yeah, well, it's a really good point. So I don't think anal sac disease is necessarily dermatological because it is often associated with colitis.
Yeah. Okay.
So there's definitely links there, and why it's associated, we don't really know, because like the lining of the anal glands is almost like immunologically distinct from the lining of the colon. So it's not like we're getting inflammation there because it's an autoimmune disease. It's a reactive disease in both sections. Is it dysbiosis? Is it stool consistency? Is it diet? Is it, I think there's so many factors that we could address with anal gland disease and colitis. What sort of anal gland disease are you seeing most commonly?
Just recurrent irritation. So sometimes sometimes it seems like very thin, watery, putrid smelling infection. Sometimes it's just recurrent inflammation and just being impacted. Seems like there's two different syndromes, but I'm seeing a lot of both of them.
Yeah.
I certainly see more hypersecretory anal sacculitis, non-suppurative, associated with atopic disorder in clinic. And I think it's metabolic inflammation that's diet driven.
Is that where you get a thick brown secretion or a very thin secretion?
No, watery overproduction, not associated with like poor stool volume necessarily.
Right.
Yeah.
That's what both dogs have. I find those ones lick their butts and the other ones scoot their butts.
Yes, that's a really interesting distinction, actually. I worked with a vet who's very experienced GP who, when I was GPing, which was quite a short time, but he always said to me, when the glands get flaccid in that sort of inflammatory syndrome, you've got to take them out. You're never going to get on top of it if they can't express themselves. It's just going to accumulate and perpetuate itself. Does anybody else have a kind of marker of when they say, okay, this anal sac needs to come out?
I prefer not to take them out, but
yeah,
my colleagues like to take them out, but I don't want to.
For me, it's signalment in spaniels is maybe when I would want to take them out before they malignantly transform.
In spaniels, yeah, okay. Have you seen any? I don't know the answer to this, but have you seen any studies that show malignant transformation in a chronic anal sacculitis?
No, not really. But I look at just like the broad spectrum inflammatory drive for like inflammation being a risk factor for cancer in general across the whole spectrum. And yeah, but I haven't seen it specifically in this.
No, and certainly we see that in the colon, colitis and adenomatous polyps, which are arising from an inflammatory condition, can certainly transform into carcinoma. So it makes sense. Typically, but particularly if it's lifelong, like if it's a young animal, I completely agree with that. But malignant transformation typically takes time and chronicity with inflammatory diseases. So if it was a 13-year-old dog who had a anal sacculitis develop suddenly, then I wouldn't be as aggressive. But I agree, there's certain signalments that we should be more aggressive about it.
No, I'm more thinking if you've spent like a year trying to address like diet and things, and the dog keeps getting anal gland issues, or move like more the ipsipated anal impaction resulting in abscesses in a spaniel, I'd maybe like, okay, there's a lot of cell turnover, probably not a bad idea to move forward, or other people may be just moving forward with them anyway at that point.
Yeah. How are you treating them out of interest? We're doing diet?
Of course. For me, yeah, fiber, get prebiotics, take up, pro-inflammatory, make the diet anti-inflammatory, less pro-inflammatory, so omega-6 to 3 improvement.
Yeah, okay.
Allergy, like feed elimination trials.
Sorry, that just dropped out. Say again.
Elimination diet.
Yeah, particularly if it's associated with HIV. What else? What other ways are you treating? Is anyone using antibiotics?
Sometimes I would do instill steroid and antibiotic, like gentamicin steroid, once or twice under sedation. That seems to help, but it seems to be only usually temporary.
Yeah. I agree. That was one of my favorite moves, but it's never long term. Any other treatments that we're using?
Is microbiome manipulation useful here? With like, as in you said, fiber as well, probiotics as well?
Maybe.
Don't know.
Fiber inclusion is the original microbiome manipulation.
That's good point. So we're going to, particularly in the colon, because the colon is where fiber is going to make the biggest difference, isn't it? I don't know if I can really tell you anything informative about antibiotics from, sorry.
I guess the other one is that management. Like, are the groomers doing it? Are the groomers not doing it? Changing up whatever the husbandry is, or who, like, how traumatically are the anal glands being handled? Maybe.
Yeah, right. I sort of see why this vet did say when they get flaccid, they need to be emptied, because as soon as you've got stasis, fluid and stasis, you're going to get infections and stuff in there, and it is going to get worse. So, but then I think it's a good point with handling the anal glands. Are you causing inflammation by expressing them all the time as well? Is my sound echoing for you guys?
A little bit.
It's pretty annoying. Could someone else talk for the last 3 minutes? Sorry.
It's distorting a lot, and sometimes your picture freezes. But I can still, I notice a lot of distortion in various people's spoken comments. I don't know whether it's mine or other internets, or it's just general.
Maybe it's the rain. The rain's back, ruined everything. Well, we might actually wrap up on that. And in a fortnight, we're going to be talking about liver disease, hepatobiliary disease, which should be very interesting. So if you've got any specific topics you want to cover, again, it's a really big subject area. So if you've got any subjects you want to cover, flick them through, and we'll just make sure we talk about them in the context of a case or something like that. How close are we to exams? 2 weeks.
Very close.
Very close. You'll be fine. If there's anything specific you want to cover, I'm happy to, or a format you want me to do this in that will help you with your exams, just let me know, because I'm really happy to do whatever you want.
Last year we did a cracking oral exam format at one point. I thought that was fantastic.
Okay. Do we want to do
doing it, but
yeah,
I thought it was awesome.
Why don't we do, I mean, I guess I know you quite well, Josh, and I'm comfortable to put you on a spot. Would you guys that are here be comfortable to be asked a sort of exam question in this sort of format? Or would you rather do a separate session where there's not quite so many people?
I'm happy to do.
Probably the separate session might be better, just to concentrate on exam technique, because there's a lot of oral exam technique that's quite different from exam technique.
Okay, so what we might do, the next scheduled session is in a fortnight. We might do an extra session in the week after that, if that's going to suit everybody, which will be 2 weeks before your oral exam, I think, or 3 weeks. And I'll prepare some questions, or I'll just do what I did for Josh last year. That's easy. Use those questions and have a bit of an answer to make sure that I'm sort of pointing out where you could have gotten an easy mark. Does that sound all right?
Yes.
The thing I've suggested to my mentees with the written is to look at the past papers and do past papers. And
for sure.
As an open book exam, more or less. And because you'll see, if you look at enough of them, you'll see patterns. But the other thing is to look at the examiners that you've got and what they've asked before, whether they have a pattern.
And do they have a special interest area? Definitely Google your examiners. All right, I'm going to cut all of you off. Bye.
Thanks, Anna. Bye, everyone.
Bye.
Bye.
Thanks, Anna.